Hey, Dr. Greenbaum. This is a case you had sent over for review. Uh, Really good discussion here about when to do socket preservations. But your first question was, can we do socket preservations or any bone grafting in a periodontally compromised patient? I sent you along a couple journal articles from the Journal of Periodontology that talks about this. Um, Long story short, we want to get rid of as much bioburden as we can. Um, Try to keep the mouth relatively clean so that the quantity of bacteria isn't significant. With that said, the studies show that there really is no compromise. And really, what it comes down to is the periodontal pathogens that cause bone loss around teeth don't necessarily care for socket preservation sites. Um, there might be some falsehoods to that, but that's been my take home message from lectures where this has been addressed. Um, any surgeon I've ever met says they don't really notice a difference when they graft in the presence of periodontal infection. With that said, it's smart to clean everything up. If you can stage it in a way to get rid of some infection first, then you're always kind of tilting the scales in your favor. But there definitely is no absolute contraindication to doing socket preservations. So if you're going to remove a tooth, make sure that you debride the site fully so that you're looking at native bone. You don't want to leave any granulation tissue in there. If you add PRF or LPRF, the L stands for leukocytes. Those leukocytes are white blood cells that will help fight any infection. And studies have shown that that is favorable at preventing infections in socket preservations and ridge augmentations and sinus augmentations. Also, we give every patient, anytime we do an implant or bone grafting, pre and post op antibiotics. So I wouldn't put a whole lot of stock into it. With that said, I don't think this is necessarily a case that you need to go and graft every site. Um, Number one, um, you're not gonna build up the bone in this area of number three here, so that you can put an implant in. So this site is unfortunately too compromised. Could you do something to it? Sure, but this guy's on a limited budget. You're not really going to do, you're really not going to go through and try to preserve all of this bone. Instead, you're going to try to find the level of bone in this manner here, the horizontal level of bone that corresponds to the implant. So what I did is I went in and I placed some implants. And if we go to the pano view, this is a little easier to describe. I went in and I put the implants where I thought the bone would be best positioned to support the implants, positioned in quantity and quality. These implant heads are, and we'll look at the three-dimensional in a second, these implant heads are essentially where the bone was wide enough to place the implants. So I think I started with number 10 because that was the most compromised site, and then I made sure that the other four implants were at the same level, more or less. You don't want to have implants at different vertical heights when you're using locator attachments. That'll cause instability of the system. You're going to excessively wear the nylon housings or the nylon sleeves that hold the denture in place. So you want to have them relatively at the same level. With that said, if you ever do need to have them at different levels, then you would consider maybe putting a bar so that the locators can be put on a bar at the same horizontal level. As you identified with the patient, we definitely want to have at least 4 implants for an upper overdenture. Some might say 6. With that said, I don't think this guy has that much bone. But I do think that this would be a great case for something akin to an all-in-4, but I don't know if this is the patient for it. With that said, I'd be happy to sit down and try to figure that out if the patient was willing to throw in more money to try to cover the costs of such a treatment plan. But it sounds like he wants to do it staged. So your objective was to remove all the teeth, put in, do some socket preservations, let everything heal, and then place the 4 implants down the road thereby retaining his upper denture and getting rid of the palate for him. Important for him to know in the meantime he's going to have a full denture. Sometimes that's enough motivation to get a patient to quickly want to go to the implants. Likewise, I've had patients that thought they'd want implants and then they realized the denture really wasn't that bad, and then they forego the implants. But it's important to know there was a study done on the percentage of functionality compared to the natural dentition of the following. So if a natural dentition was 100% function and 0% was you couldn't chew anything, a denture was 40% function, an overdenture was like 70%, and all on four fixed hybrid appliance was like 90%. There's a lot of reasons why those numbers are where they are. My point is that even if a patient goes to a complete denture and they think it's fine, we shouldn't succumb to letting them think that that's okay. We encourage them to listen to what we have to say, maybe report that study, and then let them make the best decision from there. So let's go back over to the individual sites. Let's start with number 5. So the patient has plenty of bone here after that's number 6. I don't know why the implants aren't showing up. It's almost like they are disappearing. It's in there somewhere. There we go. All right. So here's the implant in site number 6. As you can see, the patient has a lot of bone. If you were to remove this tooth and you had buccal and lingual collapse and vertical collapse, do you necessarily think that you wouldn't be able to put an implant in there? No, you'd still be able to put an implant in there. So you don't necessarily need to graft 6. With that said, I do think it's good practice, not practice like you need to practice, but good clinical practice to always try to preserve the site, because it leaves your options open for further options down the road, depending on what the patient wants. The next implant, you're really not going to socket preserve that site because there's really nothing to preserve. You take that tooth out and there's really no walls, so it's just kind of like a slant. Granted, you might have the buccal plate right here. That buccal plate might hold in the graft and you might gain a little bit of bone volume here, but then again, even if it dies back to there, you're still left with 10 millimeters. So I definitely don't think you need to, stress the guy out financially if he is financially strapped. Same with number 10. Yes, you always get more preservation with socket preservation. That's why we do it. But here you can afford to get some dieback of the bone, both buccal lingual and vertically, and still have room for the implants. Same here. Looks like there's quite a bit of bone where number 11 is. You do have the nasal floor here, but I'm confident that you can place an implant there if need be. With that said, these 4 implants are close to each other. They're all in the anterior section. Ideally, we would increase the AP spread, the anterior-posterior spread, by getting one of these implants to go back farther. Unfortunately, you're limited by this defect here. There's really just no way to preserve all of that bone or restore all of that bone without significant ridge grafting. Let's go over and take a look at it. Yeah, you can see here the infection's into the sinus. He's lost some of the sinus floor. By the time you get that out and you clean everything up, he's not going to have any bone there. Therefore, you're not going to have an implant back here to increase AP spread on the right side. And you never want to have implants be asymmetrical when you're doing an overdenture because that creates a fulcrum of instability. You want to have the implants be more or less at the same AP position when doing an overdenture. If you were doing a fixed denture, just put them wherever you can. You can put them in the pterygoid, you can put them in the nasal floor, you can put them in the cheekbone, wherever you can find bone because it's all fixed and the unit reinforces itself. So I would honestly take out all the teeth, clean everything up. I wouldn't do socket preservations here. Tell the guy to save the money for the implants, and sleep well at night, knowing that you chose the right thing. I know lots of clinicians who would socket preserve all of those. You just don't need to. You're not going to gain much to make this clinically significant for the patient. If he wants to go to an all-on-4, I'd probably say the same thing. You really don't need to socket preserve these sites because the implant bodies are going to be placed pretty far apical for a multitude of reasons. Most importantly is infection. So, all right, keep me posted on the case and let me know if you need help with the coding. Take care.